So I'm DJ or Damjana, and as Rob said, I'm the Inflammatory Bowel Disease Fellow at the QEH and starting my PhD in PSC, or finding a treatment for PSC this year. So I'm going to be talking to you about the manipulation of the gut microbiome, which a few people have alluded to, but how does the gut microbiome come into PSC, and introducing you to our clinical trial that we have coming up. So we'll talk about the microbiome, the gut-liver axis, which is what we think relates the liver to the bowel, how we can manipulate the microbiome to treat PSC, and then our clinical trial. So current treatments include symptom management, screening for and treating IBD, surveillance for malignancy, endoscopic procedures and dilatation of dominant strictures, stenting of dominant strictures, medical therapies, which Kate has spoken about, and liver transplant. So the microbiome. The concept that the gut microbiome contributes to PSC has come from a number of observations, but the most important one, or the one that we'll all know, is that most patients with PSC have concurrent inflammatory bowel disease, about 60 to 80% in studies. And we do know from studies that people with an abnormal microbiome, that an abnormal microbiome can lead to inflammation, injury of the protective mucosal barrier of the gut wall, and dysregulation of the immune system. Oh, some of my writing is gone. I might just exit this and see if I can open the other one. Sorry. So studies in PSC have consistently demonstrated an altered gut microbiome in primary sclerosing cholangitis, and this is characterized by reduced diversity and shifts in the balance of some bacteria. So that means there's less different types of microbes in people with PSC, and some of the microbes are increased and some of them are decreased compared to healthy controls. So some terminology: the gut microbiota refers to the bacteria, viruses, fungi, and more, and all of their byproducts and metabolites. The microbiome is the combined genetic material of all of these microbes and their metabolites. Symbiosis, right? In most people, the gut microbiota exist in symbiosis with their human host, being us, and which means that they help each other. So when we eat, we feed our microbiome, and in return, the microbiome does a number of important functions like nutrient absorption, digesting some products that we can't digest alone, and vitamin synthesis. It also is important in protecting that mucosal gut barrier, and it contributes to the protective lining of the gut. And when the microbiome is abnormal and causes disease in the host, we call this dysbiosis. So how does the gut contribute to PSC, and what is the link there? So we call this the gut-liver axis. And I've got a bit of an example demonstration here. So this is a cross-section of a normal, healthy bowel. And when we eat food, we absorb nutrients from that food through the gut wall. The microbiome, as you can see here, has lots of diversity, lots of different bugs, which is good. And it also has some immune cells, which protect us against infection. When the bowel is abnormal or inflamed, like this one here with all the red, there's reduced diversity, so more of the same types of bugs, less different types of bugs, and that and all the inflammation causes what we call leaky gut. So some of these microbes, which aren't meant to get through the gut, do escape through the gut wall, the protective mucosal lining, and they get absorbed into the venous system. So as you can see on the left there, all the veins around the gastrointestinal system, the purpose of them is to absorb your nutrients, and they will take them all through the liver, through the portal vein, but it also allows now these bad microbes and their metabolites to get to the liver, where they cause the damage that we see in PSC. So if the microbiome contributes to PSC, how can we change it to treat PSC? We've done this in a number of ways in recent studies, and the most common way that we change the microbiome to treat PSC is through antibiotics. The most common antibiotic that we've looked at previously is vancomycin. There have been lots of case studies, lots of case reports, and some prospective trials of vancomycin. ALP, the liver marker that we most often use to measure disease progression PSC, has been reduced in some studies, and lower is better. But in other studies, it's not been reduced. So the data is conflicting. Some of these studies have been short, there have been different doses trialed, so we do need more studies to be able to recommend what the best treatment with vancomycin is. Other antibiotics have been trialed, but again, these studies are small and we can't recommend them at the moment. Diet is obviously an important factor in our microbiome, in determining what makes up our microbiome and how it works, but unfortunately dietary modifications have not been well studied in PSC, except for the gluten-free diet. So there was one study which looked at a gluten-free diet, and again, this reduced inflammation and it did change the gut microbiome, but in terms of the outcomes that we look at in PSC, it didn't change any of them. There has been one trial that I'm aware of in prebiotics with a specific mix of 3 different types of individual microbes. And again, this didn't change any PSC specific related outcomes. So all these things that I've spoken about so far are aimed at suppressing or changing one particular aspect of the microbiome. So perhaps we're looking too closely and we need to step back and look at changing the entire microbiome to restore eubiosis. So this has been done before with fecal microbiota transplantation, which aims to restore the entire microbiome. So stool or poo is taken from one healthy person and transferred to someone with a disease with the aim of treating that disease. This is currently a treatment that we use widely and is recommended for the treatment of a severe bowel infection called C. difficile. Evidence for the use of FMT or fecal microbiota transplantation. There is also evidence, for its use in inducing remission in ulcerative colitis. So given that data, there has been one study previously looking at FMT in PSC in 2009. It was a small study, a pilot trial, so there were no controls. 10 participants received a single 90 ml fecal transplant from a single donor. It was administered by colonoscopy into the colon, and they primarily looked at safety, and the secondary outcome that they were looking for was a decrease in ALP of more than 50% by week 24. In terms of safety, there were no severe adverse side effects from the FMT in PSC. And this graph shows the outcomes of the second outcome that they were looking for, which is ALP. So these are the 10 participants which got FMT. And as you can see, some of them, and this is the measure of their ALP, So again, high is bad and low is better. So some of them did have a decrease in their ALP, some did not. There was 30% which had a statistically significant decrease. So 30% we think it worked for. This is a measure of their diversity, which we measure using the Shannon Diversity Index. And again, each line represents a different participant. And as you can see, pre-FMT, the diversity was low. So there was not many different types of microbes. And 1 week after FMT, the diversity did increase for all but one of the participants in the bowel. So that comes on to our introduction to our clinical trial. So we're also doing FMT for PSC. We're doing it a bit differently. And this is a long title, so we can call it capsules if you want. We're giving people, participants, capsules of freeze-dried stool with the aim of restoring their microbiome. So our first aim is to assess whether capsules of FMT are safe in patients with PSC and tolerable. And we think it'll be more tolerable than doing a colonoscopy. The second aim is to assess whether FMT is effective at preventing the progression of PSC and reducing symptoms and improving quality of life, with the aim of, if there is a signal for efficacy, that we might roll this out into a randomized controlled trial. So in terms of a bit of a timeline, so participants will undergo screening, and those who are eligible will go into a baseline assessment, and we'll be looking at all the things that Kate spoke about already. So we'll be doing MRI, we're doing the ELF score, lots of blood tests. They'll see a dietitian and have some dietary advice to allow them to maximise the chance of the FMT engrafting, so taking on the donor FMT. We'll do a colonoscopy, take some biopsies, and do an MRI. We'll then give people 7 days of triple antibiotics with the aim of decontaminating the bowel and allowing a maximal chance to take on the donor microbiome. And then induction phase of 6 capsules daily for 2 weeks, followed by a maintenance phase of 2 capsules daily for 22 weeks. And at the end of all that, we're going to repeat all the same assessments again and see whether everything changed or improved. We also have a sub-study where we are planning to do some portal vein sampling from a smaller number of participants, and you don't have to be enrolled into the sub-study to be part of the main study. So from that video, the big portal vein, which leads directly to the liver, we're planning on taking some blood from that portal vein and finding out what's in there, because we don't know what is in there at the moment. And this will be done at the time of the colonoscopy. We flip it around to an endoscopy and take some blood with an endoscopic ultrasound from that portal vein. And we'll do that at the beginning and at the end of the study as well. As I said, the primary outcome that we're looking for is to see whether FMT capsules are safe in PSC. And secondary outcomes, there'll be a number of them: tolerability, lots of blood tests, liver function tests in particular, fibroscan, MRI, looking at whether the inflammation related to IBD also changes, looking at patient quality of life, symptoms, dietary assessment, and of course, looking at the microbial composition and function. Thank you.